So now we will discuss about the Adductor canal block with Philippe GAUTIer. Okay, up to you, Philippe.
So the Adductor canal block has been described these last years and very consistently to be as effective as the femoral nerve block and to provide a lower motor impairment. This is well established. This block is usually performed, or is always performed, is always performed here, very close to the femoral artery that is located there. And this femoral artery is surrounded by the sartorius on one side, by the vastus medialis on the other side, and the adductor on the third side. And you have just seen here that the local anesthetic has been injected and is surrounding now here the vastus medialis nerve, and in a few minutes, most probably, the saphenous nerve that is located there. As I say, this block is performed at the mid-tide, but while looking very closely to the papers that has been published, the mid-tide can be located depending on the starting point, really at two different levels. This means that from time to time you are performing a cephalate block that is in fact a femoral triangle block, while on the other times, when you are puncturing slightly more caudally, you are performing an adductor canal block. And this is extremely important because the surrounding nerve around the femoral artery are changing while going caudally. At the start, we see all the branches here of the femoral nerve. Downside, when you performed a femoral triangle block, you have just the vastus medialis nerve and the saphenous nerve there. And when you puncture more caudally, when you do an adductor canal block, you have just the saphenous nerve. At this level, you are working behind the vasto-adductor membrane. Here is the femoral triangle. You have the sartorius, here behind you have the adductor longus, and this triangle contains the femoral vessels and the femoral nerve that is going to split. When you perform here at the top of the femoral triangle, your block, this is exactly what you obtain, a spread of local anesthetic around your femoral artery with an anesthesia of your vastus medialis nerve and saphenous nerve. And this is exactly what you are looking for, as the surgeons are going to open the knee here using a medial parapatellar incision. That's great. On the other hand, when you perform an adductor canal block, you are working just above the hiatus. A few minutes ago, we were working here at the tip of the triangle, at the top of the triangle. Now we are working here behind the vasoadductor membrane. This membrane is an extremely strong membrane, so that you have no compliance at all, so that the local anesthetic solution that has been just injected has to go somewhere. And this local anesthetic solution is going downside caudally in the popliteal area. And when you look to this image, to this spread, you have the sartorius here, vastus medialis muscle, the biceps muscle, the sciatic there, and you see that the local anesthetic is spreading from one side to the other side. As a consequence, you have an anesthesia of the saphenous nerve that is responsible for the infrapatellar area, but you have mainly and first of all a lot of local anesthetic that is located at the around the femoral vessels here. And in this area, you will find the popliteal plexus that contains branches of the obturator nerve, of the tibial nerve, of the sciatic nerve, and that is responsible for the innervation of the posterior capsule. Moreover, we have local anesthetic going very close to the sciatic nerve, and from this area, you will have the genicular branches. So, we have in fact two blocks. One block that is a cephalot one, a femoral triangle block, where the primary target are the saphenous and the vastus medialis nerve, and depending on the volume and of the spread of your local anesthetic, you will have more cephalot branches. On the other hand, because of the vasoadductor membrane, the local anesthetic will be launched downside, and you will have perhaps or certainly the saphenous nerve, but it is probably not the most important nerve explaining the mechanism of action of this block. You will have a major collateral effect at this level, including the obturator nerve, the superior inferior genicular nerve, and the plexus in this area. Thank you.
Thank you, Philippe. A wonderful presentation. As usually now, the last quiz about adductor canal block. The question is, the block at the adductor canal provides analgesia equivalent to the femoral block after TKA. Once again, you have 10 minutes during the live demonstration to answer. I have a question from Algeria. The question is for Sébastien or Olivier. What is the volume you use when performing a femoral block plus an obturator block plus a sciatic nerve block?
It depends on my finger. No, sometimes no more than 30 mils. And it's clearly depends if you add a sciatic or not. When you perform the four blocks, femoral, obturator, sciatic, I try not to use more than 40 mils, but under ultrasound, clearly it's not difficult because for the, I don't know your opinion, Olivier, but for the sciatic, 10 or 15 is enough. Sometimes 15 is enough. For the femoral, 15 is enough, and you have 10 more for the other one. So, but the other possibility is clearly but you know that Alain is to have very low concentration, then you can enhance the volume with a good result and without any problem of toxicity. So I think that it depends of your if you're an expert or not, to decrease a little bit the volume and the concentration you use, and so there is not a clear answer in my opinion.
Yeah, I agree, because in fact dose is also very important depending of the concentration you use. Okay. Just now it's Philippe is ready to go. Okay, Philippe, up to you.
Thank you. This is the slide that we have just been shown by our colleagues. You have the femoral artery that is located here. You have the femoral nerve, and most importantly here, you have the sartorius. When you move downside, progressively, you will have the sartorius going above the femoral artery. You see the femoral artery, you see the vein. We have most probably here the vastus medialis nerve, and here the saphenous nerve. We go downside, and many anesthetists will do their block at mid-tide at this level, with the needle coming from here to there, and they will inject this area here very close to the artery. This block is the triangle block. Now, should you move downside your probe, you see that the sartorius that is here will overlap progressively the adductor longus. And at this level, when the medial edge of the sartorius is crossing the medial edge of the adductor longus, we are entering literally in the adductor canal. And you see that in some case, and in this case, it's possible to see the white area here is becoming thicker. It is the adductor membrane. At this level, you see that the femoral artery is going to dive. And because this membrane is so thick, because the compliance of this area is so low, the local anesthetic has no other solution to escape and to go downside in the popliteal area. And this explains most probably most of the effect of the caudal approach. That's all. And I'm coming back to you.
Okay, thank you, Philippe. Just a question for the other. The result of the quiz is yes on 38% and no on 63%. So most of you think that femoral block is more effective for pain relief in TKA than adductor canal block. For you guys, do you use adductor canal block regularly, or do you prefer to use peripheral nerve block, more proximal peripheral nerve blocks?
So in my practice, and I will ask to Olivia after, in my practice it depends clearly on the surgeon. I work with a surgeon, I use adductor canal block every time because he is very confident with infiltration. So the addition or the combination of adductor canal and infiltration will have a very good result. And for other one, or for patient in the end of the program, so in the afternoon, I prefer femoral nerve block because some of them are less confident with infiltration, and clearly I prefer femoral and sciatic. And it's the same for patient in the end of the program. In the afternoon, I prefer this proximal block because I'm sure that the patient will not work during the night. So
it's the same for us. I agree with you. Same for us.
Okay, perfect. What do you think about the result of the quiz, Philippe? 60% think that femoral block is more effective than adductor canal block.
Yes, I agree.
You agree too?
No.
So I will
no.
change the question.
No. The answer is that it depends exactly what you are looking for. If you are looking for a very fast recovery, then local infiltration analgesia, infiltration together with an adductor canal block. If your kinesiologists are extremely proactive, yes, there is certainly some interest for this technique. Now, in many cases, patients don't move the day after surgery immediately. And depending on the surgery, depending on the quality of the infiltration, I think that we all agree on that. A femoral catheter will be more valuable in more cases. Perfect. It depends of the options.
Second question, when performing an adductor canal blocks in your daily practice, do you use a double injection, proximally more or less at the femoral triangle block, and distal injection, or do you use just one single injection of 20 mils of local anesthetic?
So, as you know, I like catheters, so in most of the cases I insert a catheters. My entry point is located quite high in order to be very far away from the surgical site. So it means that when I approach, I first do a single shot located in the close to the vastus medialis and at the top of the triangle, and then I insert my catheter and I leave the top of the tip of my catheter very close to the artery when she is diving. So in fact I do both of them.
Yeah, okay, thank you. Last question. Do you think there is any difference between distal injection just beside the vessel in the adductor canal, in a distal adductor canal block, and an IPAC, because more or less the picture is the same, the spread is more or less the same. Do you think there is something very different, or do you think it's more or less the same spread?
So, first of all, there are no data on this topic, there are no studies, so it's impossible to say exactly. What I believe is that when you do a distal adductor canal block, you have probably 40–50% of your local anesthetic solution arriving in interpopliteal fossa. When Olivier performed an IPAC, 100% of his solution is located at a good place. So the IPAC is probably more selective. Probably. This would be my option.
Okay, thank you, Philippe. So now at the conclusion of this session, thank you to attend this session, and just to conclude, to say you have the possibility to make peripheral nerve blocks or femoral obturator and sciatic, or also it's always possible to perform adductor canal blocks and infiltration. Thank you for your attention.
Thank you.